Case of a male, 49 years old, no known underlying disease. So his chief complaint is he had a left shoulder pain 5 weeks prior to admission. Um, so so he have a history of fall on his left shoulder. He fell and his left shoulder directly hit the ground, and he was diagnosed with anterior shoulder fracture dislocation on his left shoulder, and his left shoulder was reduced at Bangkok Hospital. After that, he could not elevate his left
in
shoulder.
Bangkok or in ราช
At
สีมา
Bangkok, at Bangkok Hospital ราช
ราช
สี
สี
มา
มาโคราชเนาะ
ใช่ครับ
เกิดเหตุแถวนั้นเนาะ okay so this is the X-ray okay of the shoulder at the first time at Korat นครราชสีมา okay Money read the film if you're the first doctor
Oh, this one.
yes
So this is a film of
come here
49.
Money look at this one
So this is the film of a
Explain.
49 years old man. This is the
Yeah.
film of left shoulder AP view. So as you can see, like the head of femoral, not head of femoral, head of humerus is like have like dislocated anteriorly since like you can see like
could you tell that
เอาไม่เห็นไปวัน this is because the first actually it will be easier if we see like the lateral view.
Okay. But anyway, if you look at the position, sometimes you can tell this is the anterior posterior, okay? Because most of anterior dislocation, the humeral head will displace anterior inferiorly, okay? Never anterior only, there's an antero inferior. So the position of the humeral head is here, right, at the beginning. So now it's moved anterior and inferior, okay? It's different from the posterior dislocation. It's never go posterior inferior. The posterior dislocation will be like just posterior, okay? So the humeral head will be at the same level. It's not changed. So the deformity will be not different, okay? So you can tell from the deformities that this is anteroinferior. Okay? So this is the should be anterior, but you can prove by these films. This is the what do you call these films? No, transscapular or scapular wide view. Okay, you look at the scapula, it looks like Y, right? This is Y. Okay, so this is posterior, anterior, glenoid in the middle. So if the shoulder move anteriorly, that means close to the rib cage, right? To the this is a lung. So this is anterior. Okay. Okay. What else?
There's the head of humeral fracture like here. Is
You
that-
call head?
It's greater tuberosity
Greater tuberosity.
of humeral head fracture. So
Yeah.
that's all I see.
That's all you can see, right? But actually, if you look carefully, that is the glenoid, right? Can you see this one? There's something, okay, but not clear. It may be a part of the head, or it may be the part of the glenoid, okay? But this is not normal. Okay. So what will you do? And
Since this is dislocation, so the first thing is to re-dislocate. So put it back.
open or close? นี่เปิดหรือปิดอยู่เนี่ย
ไม่แน่เปิด
เอาเปิดตรงนี้
reduction. So reduction and mobilization.
how to reduce this kind of fracture. Thanapat, switch.
นี่ตาม
Hmm?
เขา like do the action the counter act traction and counter traction
Again.
track traction and counter action yep so one
Traction, counter traction.
yeah traction counter traction
Repeat it 3 times.
traction counter traction traction counter traction and traction counter traction yep
Okay. You can remember now?
yep
Okay. So actually there's many ways to reduce this dislocation. I think for medical student this is the safest way, okay? Because you don't need to move, you just track, okay? And counter traction. There's many ways. Actually someone do manipulation, okay? Or we call the leverage technique, okay? That's sometimes is the bone very soft or you have the broken tuberosity, you may create the fracture the head. So I think for the fracture dislocation, this patient you have fracture, right?
Yeah.
At the tuberosity. If you try to do this way, okay? This is like a leverage technique. Okay? Napat, come here. So let's say you have dislocation of the shoulder, okay? Like this. So the patient we came to see you with abduction. You see the shoulder abduction, right? See? It's abduct, okay? So the shoulder came not like this. So this is a classic position, and the patient also hold the arm like this. So that's the position that very classic at the emergency room. Okay? And if you look at this, you can see the gap. You see that? There's a gap, okay, between the acromion and the head. So if you look from external appearance, you can see there should be a gap, okay, or we call sulcus underneath the acromion. Okay, if the patient very slim, you can see very well. But if the patient thick like you, maybe you can see the deformity. Okay? And also you can see that the arm is longer. Okay, you can imagine because it moves inferior, so this arm will be longer. And this is a classic position. Okay? At the emergency room, after you suspect this dislocation of the shoulder, okay? Asking about the mechanism of injury. Okay? Before you try to do reduction, you should examine, okay, the neurovascular also. What is the neurovascular at least?
the axillary nerve
Axillary nerve. How to test the axillary nerve?
the sensory here at the deltoid
Okay. หมุนตัวนี้นะครับ So where is the sensory of the axillary nerve?
below deltoid insertion should be like around here
It's around here. Okay, this area. So the area is very small. Okay. If you did not test it, the patient will not tell you that you have numbness because the area is very small. Okay. ตอนแรกตรงนี้ชาไหม
ตอนที่เป็นแรก
ชาไหม
ๆไม่ชาด้านนี้ด้านไปข้างหลังนิดนึงครับ
ไปข้างหลัง
ตรงนี้ครับ
ตรงนี้เนอะ
ใช่ครับ
ตอนนี้ชาไหมครับ
ไม่ชา
ไม่ชาตอนนี้รู้สึกดีนะ
รู้สึกดีครับ
No. So you need to check always, right? The axillary nerve. It's in this area. ขอโทษนะคุณหมอวง
ใช่ครับ
So the area is very small. Like this. Very small. ไม่ชาเนอะ
ไม่ชา
รู้สึกดี So that's the first nerve at least. What is the second one? Radial no. What structure underneath the coracoid? Sunapat. Thank you. Next one. วิธีการ What is the structures? I mean the neurovascular structure. Axillary nerve. Axillary nerve is from the quadrilateral space, right? And it's coming from here, okay, and then go around. So the axillary nerve is at least because the dislocation, the axillary nerve is getting out of the axillary pulse here. right? So this area there's a quadrilateral space and it's go around the humerus. So the nerve injury will be here, okay? If you can remember the brachial plexus, right? Okay, what nerve is here? Is coming from here. The musculocutaneous nerve, right? The patient would have numbness at the area of the lateral aspect. This is a lateral cutaneous nerve of forearm. So patient will have numbness in this area. So this is the two common nerve injury. And if the mechanism is very severe, the patient may have the brachial plexus injury, but it's not common in the young. Yeah, it's common in the elderly patients. Okay? So you need to check the nerve always, every time before and after the reduction. Okay. So after you check the nerve, send the patient for X-ray, and then the patient come back. You got all information, and then you do the reduction. Okay. วิธีการ how to reduce the shoulder.
How to?
You told traction, counter traction, how to do that.
Should I have two people
Mhm.
help each other? Someone like who
Mon. So Mon, she had dislocation on this side. Okay. So you're the doctor. You are the nurse. Come here. Okay, Mon, how to reduce? In supine, let's say she's supine. Okay. Okay. เอาผ้ายืมนะครับ
อันใหญ่ไหมคะ อันนี้
นี่ยาวกว่าเนาะ So let's say we wrap around this.
like she's lying supine.
Supine. We wrap around this. Okay, and then so she wrap around this. Okay, this way. This way. Okay. Okay, to the axilla that way. Okay, and then you track opposite way. Yeah, you hold it like that. So the way you stand, you should go this way. Mon.
Like this.
Okay, like sailing, like this. Okay, you use the gravity and gentle traction, steady, not jerky movement. Okay, and it's not reduced right away. You need to wait for muscles relaxation, stress relaxation. For most of the time, it takes you minutes. Okay, 2-3 minutes. Depends on the laxities of the joint. Okay, that is a traction, counter traction. Okay. You should it awake or under sedation? Under sedation. Okay. Which medicine?
Actually, Valium would work. Valium and morphine.
Diazepam. Or Valium, right?
Can we use fentanyl?
Fentanyl also. But I'm not sure at the emergency room you have the fentanyl. Okay. Valium is very safe. Okay, 10 milligram Valium. Okay. With or without pethidine, this depends. Most time Valium is okay. So the concept is that the patient need to be relaxed, sleepy, relaxed. Because if the patient is still awake, the muscle contraction will against you, and you cannot reduce the shoulder. Okay, that is the first way. Okay. But this patient, he had the tuberosity fracture. So that's an issue that if the patient have tuberosity fracture or dispressed, you have the rotator cuff, right, attached to the tuberosity. So the problem there is when you try to reduce, if the tuberosity fracture, that means the patient have like no rotator cuff, if it dispressed, because that's the attachment of the rotator cuff. So there will be no muscles that try to reduce the head back, because you just disengage, right? But you need the head depressor. That is the rotator cuff. Because of the function, rotator cuff is like this. Okay? I told you already, right? Rotator cuff, there is the fold, one on the top, supraspinatus, infra, teres minor. This is bicep, right? It's a subscap. So when you disengage the head out of the socket, then the rotator cuff, the rest will pull the head back. imagine that you have tuberosity fracture or you have the torn rotator cuff. It's like you have no rotator cuff attached, this 1, 2, 3, right? No attachment to the tuberosity, so that we have no head depressor. So another trick to do that way, you have tuberosity fracture, or the patient, the elderly patient have dislocation. So sometimes you just track, it will not reduce. So the trick is that you need to have another, okay? Okay, let's do this again, like this, okay? And your friend, like this, okay? That way. And you need another one. Okay, come here, you track one. Okay, you go around the same way. Okay, same way, right? Here. So this is traction, counter traction, right? Tanapat, you hold this one. Understand?
I pull it back.
Yeah, you pull it like this.
Also,
Up.
it's like work as like a function
Yeah,
of
yeah.
the
This is
rotator.
like rotator cuff function. You try to pull the
So
head
the
back.
direction is upward.
Upward, right? Upward. So you have this, this, and this, right? So this is a modified. So it's good for the patient that have torn rotator cuff, or the patient that have tuberosity fracture. This is safe. Okay? Try to not to make the leverage technique or zero position like you do, because if you have torn rotator cuff or you have the tuberosity fracture, if you try to lift like this, what would happen? You will have the fracture here. Okay, many times. Okay, I saw many patients refer to me because they do the leverage technique or zero position technique, right? Or muse technique. So when they lift up, it's broken. Can they draw?
Yeah.
Mhm. So let's say this is a glenoid, right? And the shoulder dislocation. Like this. Okay. Like this. Okay. So if the patient have tuberosity fracture or this is a big heel sac lesions, so you try to lift up this way. You see that? That's a force. Okay. You can break.
So the
Understand?
bones
Yeah, you can break because the bone is impinging. So this leverage, there's no traction. They just lever. Okay. So it's good for the simple dislocation. But for the patient that have the tuberosity fracture or they have the heel sac, big bone defect or poor bone quality, it's very risky, right? Because you change the prognosis. Whenever you break this, this is anatomical neck. This piece of bone will be die, you know, a vascular necrosis. So this is very risky. Okay? So I recommend you to do this way: traction, counter track, itself, or the modified one. Okay?
So,
Yeah. Any
So-
question, Mon?
so in this patient, he's most likely, like his shoulder should be reduced by the technique.
This
that you
way.
just used.
Yeah, I think this way is safer.
And the one more helper with
Yeah, right. Right.
with
Okay. Okay, good. Next. So after the reduction,
อาจารย์ค่ะ
huh?
Then there's like the another reduction technique, the one that like have to push the glenoid.
Yeah, that is the.
Would that work?
You know, there's over 100 techniques for reduction. So another way is that you have dislocation of the shoulder. Okay, you don't reduce the shoulder, but you reduce the glenoid by manipulation of the scapula. Okay, to reduce the scapula back. Head is here. You reduce the scapula to the head. We call the scapular manipulation technique. Okay, not easy. Okay, it's not easy. Sometimes you cannot move the scapula nicely. Okay, that actually there's many ways. The muse technique or the zero position technique also very good for the simple dislocation. Actually, you can see my presentation in the YouTube. Okay? So you just track for a while, and you can do that awake, but you need keep talking to the patient to relax him, right? And then the way to do that is like this, do traction, okay? And then you try to supinate like this, okay? This way, so let's say the patient sleeping on the bed. So you're starting with this is a position of dislocation, right? Extend the elbow first, okay? Relax, gentle traction, okay, without counter traction. Slowly, okay? So the patient body weight will against you, okay? So you try slowly, like that, slowly, like that, okay? Slowly, like that, until you go this way. So also external rotation, okay, like this, you external rotate, this, okay? Elevation all the time, okay, until this, okay? It will be reduced very gentle. Sometimes you didn't feel that it's reduced, okay? And then you go down this way. So the patient can go back with this do guard, right? That means the shoulder reduced. If the patient can add duct in rotate, that means it's already in the socket. Okay? Good. So I'm not sure which technique he was reduced at the Korat, right? But maybe under sedation ก็ฉีดยาชาให้ใช่ไหม
แวเลียม10
แวเลียม10ใช่ไหมแวเลียม
แล้วก็เท่าที่รู้สึกตัวคือเขาผ้าสอดแล้วก็หลับไปเลย
10ผ้าสอดthat should be traction outer traction so that's okay so after the reduction expand the film on turn to your friend like this
I think it's reduced back into the glenoid.
it's good reduction
But maybe the line, the
gothic arm
gothic arm is a bit not perfectly aligned. Like this part. Yeah, and then there is the closed fracture of the greater tuberosity of the femoral head
yeah
on the left side. And what is, I'm not sure what is this one.
that is colloquial process
Colloquial process. Like
colloquial process
behind, and yeah, I think that's all I see.
Okay, so the tuberosity is still good. You look at the tip of the tuberosity, it should be lower than the head, right? This is the head. The tuberosity should be 8 millimeters if you measure the distance. We call head tuberosity distance, right? This look good, and this is not so much distress. I think we can treat this conservatively. The bone can heal nicely, and the cuff function will come back. Okay, don't need surgery for this, right?
So
If you look carefully, you say gothic arc is not so nice, right?
yeah.
But actually, that gothic arc, we're looking for the very true AP. We call the gauche view. Gauche view, right? This is not gauche. This is the APX shoulder, not the true AP. Gauche is a true AP shoulder. You should put it perpendicular to the glenoid, okay? Okay, and you see something different, something strange.
Here?
Yeah, you see here's this piece of bone, right? It should be in this line. Okay. ท็อปไม่เป็นไรอ่ะเดี๋ยวรอเลนส์เขาถ่ายให้แล้วนะเดี๋ยวท็อปไปเคลียร์เรื่องเอกสารไปเคลียร์เอกสารที่ OPD นะ so this piece is
Oh, so it's broken in the glenoid.
yeah
Yeah.
if you look there at the glenoid that should be like elliptical shape there will be the posterior rim of the glenoid and the anterior rim, you know. It's like a rugby shape, rugby elliptical shape. You should see front and back. But if you make it perpendicular, you cannot see front and back because it's parallel, right? Okay, but this film is not parallel to the shoulder. Okay. So the true APV is like this. We call gauche because our scapula is about 30 degrees from the body plane. So if you want to make it perpendicular, you need to project the beam out 30 degrees. That is gauche view. But this film is like true AP. You go perpendicular to the coronal plane. Yeah, like this. Okay.
And do we have to Can we test the rotator cuff function of the patient?
No, no,
after
no,
reduction?
no.
They will be in pain.
Yeah. It's pain, and you see the tuberosity fracture already. You don't need to test it. Okay. And now you see the Y view. It look good.
Yeah.
Yeah. This is the Y view. You see the head coming back right to the center. That means it's already reduced. Okay, it's already reduced. First time dislocation, do you need surgery?
In if in the young
In the young, that means you. Money, if you're first time dislocation, do you need surgery?
มันมีแยกแบบยังกับโอที่แบบมันจะมีคนที่ต้องการเซอร์เจอรี่กับ if in the young ปัญหาแบบขับแพ้ก็เลยเราต้องเซอร์เจอรี่ค่ะ first time in the young อาจจะไม่
First time in the young.
ใช่ไหมเท่าที่จำได้
First time in the young.
first time in the young อาจจะยังไม่
ไม่จำเป็น So he's young, right? Why I did surgery for him?
is it because of the green
Maybe like
the green
The glenoid.
he has persistent shoulder pain afterwards, and we think it's from like associated like labrum tear or the bony lesion that Ajahn point just now.
So most of the dislocation in the young will be simple with dislocation. What means simple? There's no bone fracture, no socket. Socket is glenoid, right? No socket fracture, no tuberosity fracture. Okay. That means that's torn from the soft tissue part. Okay. So can I draw? So when you have dislocation, you imagine this is a glenoid, right? That's the head. Okay. So when that's dislocation, can I draw again? Yang looking. So there's a capsule here, right? Attachment. Okay, that is the shoulder, and there is the triangular shape. What is that? No, that make the socket deeper. Labrum, we call this labrum. Okay. Trichy is the knee, and that is a capsule. No, it's different. So that capsule, that's labrum, right? So the shoulder joint, the socket is very flat and also smaller than the head. So the stability of the shoulder is depending on the soft tissue, the capsule labrum. So when the shoulder dislocates, this structure always torn from the bone. Okay? Is that when dislocation, the labrum will be torn from the bone. So you look at this, it will be floating like this, together with the capsule. Okay? So that is the entry part. So that you can see that it's floating, right? So that's why the shoulder dislocate again, because after the dislocation, let's say this is simple dislocation, you have no bone pathology. So the shoulder will dislocate again because the anterior capsule and also labrum is torn. Okay, we call this the Bankart lesion. Bankart lesion. Okay.
So Bankart is the part of the
Labrum.
that
That's right. That is the labral tear. You can say labral. Anterior labral tear is a Bankart lesion.
So in order for this to be torn, the anterior
Yeah.
needs to be.
It can be torn from the capsule tear, but most of the time the torn is from the labrum. Okay, you may have this, but this is in the young. Okay, and also when you have dislocation, this part of bone will be here, right? Like I show you one picture. So there will be a bone defect here. Why? Because when the shoulder dislocate, okay, the head will be here, right? Okay. So when you reduce the head back, that's why the defect is here, because the shoulder dislocate to the front, but there will be the defect of the head in the back. We call this defect USAC. Now you understand why, right? Okay, this is the defect at the head. And sometimes the patient may have the defect here also. Can you change the colors? Yeah. Sometimes the patient also have the pathology here. That is a part of bone, right? Anterogrenoid rim. That can be broken. Okay. So in the simple dislocation will be labral tear or there will be heel sac lesion. But this patient is different. He had this big piece of bone broken. Okay, we call this the bony Bankart. Bony Bankart. So that's why he needs surgery, because this is not the simple dislocation. And this bony Bankart is a very big piece. If you didn't fix it, the patient will have dislocation for sure. And if you come too late, this piece of bone will resolve. And finally, he needs the big surgery. Okay, I need to transfer the bone from somewhere to put this back. So that's the big surgery. Okay? So that's why this patient needs surgery. So from the image, I think there should be something here from the image. Okay, but for you guys, you are not have some enough experience. Sometimes you can miss this problem. Right? Okay. So after we look at spatial view, you can see this view. So this view you can see very clear that the patient, this is anterior part, this posterior part. Okay.
Disrupted, right?
Yeah, it's disrupted, right? I'll show you here. Go back.ยังลบอยู่นะ You look at this. You look at this. Okay. You see it white. No more white. See? That means the anterior part is gone. And this part is dropping down. That means this piece. Okay. So, what is the next investigation? You suspect that this patient have the bony Bankart. It should be big because you see that it's disrupt very high, right? If you look at like this we call the cock face. This is like 12 o'clock. This is like 6 o'clock. Okay? Clock face. Okay? So that is a clock face. So this is like 3, 9. Okay? So it's extending like from 6 o'clock to 9 o'clock, right? It's quite big. A quarter, right? Quite big. So we need next investigation, right? MRI or CT scan. Okay? If you want to see the bone, this is a CT scan. You see that? Very clear, right? This piece of bone broken. And it's quite comminuted, big piece of bone. Okay? So if it's bigger than 25%, we should fix it back. But anyway, if there's a bony Bankart, big piece, that's an indication for surgery. Because if you did not do the surgery, the patient will come back again with dislocation. And this location will be very simple, will be very easy. Just move, it's dislocated. Okay. So that's why we need to address this patient earlier. Actually, he's quite busy. He's the lawyer. He's very busy. But I told the sister that he should come very early. Otherwise, it will be difficult for me to fix it back. Yeah. So this is about 4 weeks, right? 4 อาทิตย์นะ
5
อาทิตย์นะ 5 weeks.
So what if you only have labrum tear? Do we have to undergo surgery?
Yeah, labral tear, just labral tear for simple dislocation like Nanta, right? If you're the first time dislocation, I will not operate you because you're not active. Your sedentary lifestyle, right? No sports,
No sports.
Yeah.
No sports.
eating, sleeping,
And study.
studying, right? So for you, if you're the first time dislocation, I think you're not the good candidate for surgery. I will wait for the second one. If you, because some patients they change their lifestyle, okay, they will not dislocate again. You know, so that's not every dislocation needs surgery. If you have no bone defect, okay, you don't have the tuberosity, displacement, you don't need surgery.
What if there's a posterior tear that you said that was also be like a fracture,
Mm-hmm.
like the one that you drew? Do
Yeah.
you need surgery for that?
Yeah. So if you have the broken
But
glenoid,
if it's only broke here, you
yeah,
don't have to do surgery.
yeah. Most of the time, this heel sac and the band cut always come together.
Oh, okay.
Yeah, the soft tissue one, the soft tissue band cut, right?
Mm-hmm.
Or sometimes the heel sac. But the heel sac depending on the how many time dislocation. Most of the time you have first time dislocation, this heel sac always small. Okay. You have multiple dislocation, this heel sac getting bigger because you have repetitive injury like that. Okay.
So the first time, even if there is a fracture here, you don't have to undergo surgery.
No. So that is a depression fracture. It's not a fracture. It's like depress of the head. Okay. Also the tuberosity fracture. If you have tuberosity fracture, most of the time this piece always reduce nicely after the reduction. Okay. So it's not displaced more than 5 millimeters. You don't need surgery also. Right. Like this patient, the tuberosity is reduced and no displacement. So I don't need to do anything about this. Right? We just wait for it tuberosity to heal, okay? And the function of the little cup come back. So this patient we need surgery because this is a broken bone. We call bony band cut, big piece. Okay. And nowadays there's a new trend. If you are active, let's say who's active? Supatida. You active, right? Chutimon, she's active, just the first time dislocation. But Chutimon, she's the professional athlete, okay, like volleyball player or overhead athletes like baseball player. That she need overhead activities. That's risky, right?
Yep.
This position is risky to dislocate again. So you can predict that she would have the second time, third time dislocation. Okay, that's another indication, right? Number one is the patient that have bony band cut, big piece. Number two, the patient first time with active overhead athletes, okay, and the patient that have the career that is very risky, like there's a firefighter, diver, okay, mountain climber, something like that. So that also risky, right? So you need the surgery for them because it's risky if they have dislocation. When they're working, they should be life threatening, right? So that's also the indication, right? Good. This patient, the surgery I have done actually this one I don't need the MRI because the CT scan is more appropriate because you have the bony problem, right? And also I check his cup function is fine. So when we get in, we find that the patient have the broken piece of bone here. Okay, it's comminuted. Okay, so I need to detach it first and try to fix this back. You see, there's a broken bone, and this broken bone attached to the labrum. So when you have broken bone, you look at this. This is the bone. See, and you see this is the labrum. Okay, that's the bone. Okay, and there's a cartilage. You see, very big piece. This is 6 o'clock. So it's broken like this. So I need to reduce this back. Okay. So we do the keyhole surgery. Nowadays the keyhole surgery works very well, and you don't need to make a big cut all the muscles and reattach. Okay. Nowadays the arthroscopic or keyhole surgery works very well for the instability surgery. So we pack the suture in and then we use the suture anchor, put in the bone, right? Because you need to fix this back to the bone. And also this is absorbable, it's in the bone like this, okay? Look like screw, okay? Put in the bone. And after that,